I call the November 5th, 2025 meeting of the Seclusion Working Group to order, and a quorum is present. Our first order of business is approval of the previous meeting minutes, and I hope everyone has had a chance to review the minutes from our previous meeting. And is there a motion to approve the previous meeting minutes? All right, we have a motion to approve the meeting minutes. Any discussion on the meeting minutes? Seeing no discussion, all those in favor of approving the meeting minutes from November 5th, 2025, say aye. Aye. Any opposed, say no. All right, the motion carries and the meeting minutes are approved. We have a few new members to our group. We had two members resign, well, one resigned, one retired, and our new members have been appointed. So we have Greta Chose and James Schmidtke. And I'll give each new member an opportunity to introduce themselves to the working group. Ms. Chose, do you want to go first?
Yes, thank you. I'm Greta Chose. I'm the Director of Children's Programs at NAMI, Minnesota. I am replacing the newly retired Sue Abderholden, who was on this committee before me. My background is in law, but more importantly for me is the lived experience with a daughter who had extensive mental illness, and so this discussion is really near and dear to me. So I'm representing NAMI.
Thank you, Ms. Chose. And Mr. Schmidtke, is he? Oh, he's running late, so we'll come back to him when he appears. Next on our agenda, we're going to have a few presentations today on school-linked mental health services. And our first presentation is by Teresa Steinmetz, who is the DHS Assistant Commissioner for the Behavioral Health Administration, and Christy Grom, DHS Director for State Government Relations. I'll invite you to come forward. When you're ready, you can begin.
You can just control it by the up and down. Okay.
Yeah, if you can, that'd be great. All right, hi everyone. So as you heard, I'm Teresa Steinmetz, the Assistant Commissioner of the Behavioral Health Administration at the Department of Human Services, here today to talk with you about some of the school mental health and substance use services that are provided and supports that are given in the state of Minnesota through various schools at this point in time. So there are a range of services to support both behavioral health, which we say to include mental health and substance use challenges for youth in schools. Some of these services are provided by school staff. Some are provided by community partnerships where clinicians might come into a school and offer services, and can include various different supports and services such as psychotherapy, skill building for the youth, psychoeducation, consultation and training for school staff, supportive services not just for the youth, but for the family of the youth as well, evidence-based treatment interventions, and special education supports. These services can be covered through the Minnesota Healthcare Plan, which is the federal Medicaid program, or through grant funding, such as the School-Linked Behavioral Health Grant Program. School-based behavioral health services can really provide interventions and supports to help lessen crises in schools and behavior escalation for youth, and can really play a role in helping to reduce the need for seclusion and restraints in school-based settings by providing early identification and intervention before the behaviors or the experience the youth is having might escalate into a crisis situation. On-site mental health professional behavioral health services on-site mental health professionals can offer consistent support. They can help to teach coping and regulation skills to the youth, and they can also serve a role in collaborating with staff in those schools to model trauma-informed de-escalation strategies. This partnership is really important as it can, again, support the youth, but also equip the educators to respond safely and effectively to students who might be dysregulated at some point in the day. That really contributes to creating a culture of trust rather than a culture of control of behavior. Not all of the behavioral health services provided in schools are provided by grants. Schools are expanding their capacity to provide behavioral health services through school-based community services, which is a service that includes third-party billing to Medicaid. These services are typically identified as medically necessary and provided by a qualified healthcare professional. Another option for supports in schools is mental health and special education. That is a specific set of services for those children within special education, those children who actually have an individualized education plan, an IEP. This benefit was implemented in October of '24 after the school social work special education legislation passed in the '24 session. It really tends to support the highest risk and most complex youth with service intervention, and is really a part of the Medicaid benefit package. The federal Medicaid share is then reimbursed to the school that is providing the services as an unenrolled provider of Medicaid. At this point, 16 schools have started billing for these services, with continued growth anticipated this school year. DHS has a school-based team that works in close partnership with MDE, and they have completed multiple technical assistance sessions, trainings, and continue to support the expansion of this benefit. The last service and support within schools is the school-linked behavioral health services. These are grants programs administered through DHS that support services to students that are uninsured or underinsured without other means of coverage and other means of accessing services. The unique thing about this program is that it also can include supports and training for teachers, as well as supports and services for the parents of youth within the program. We know that youth are 6 times more likely to complete treatment when it is brought to them in a school setting. Meeting the youth where they are at helps to reduce barriers to treatment and also has a lot of other benefits as well. It can increase access to services and supports. We know many families face barriers to community-based care, transportation, other means of accessing care, and providing services in schools can ensure that the students receive help where they are already located. School-based care can also level the playing field for students who may be in rural, low-income, or under-resourced communities by increasing equity and increased access to the care within the schools. Early identification can also allow issues to be addressed before they escalate into crisis, playing a key role in prevention of continued escalation of challenges for the youth and the student. Some of the good impacts that we see through school-based intervention services are that students who are receiving behavioral health supports really show an improved attendance, improved focus, and tend to have increased academic performance. We also know that funding is stretched then, especially at this point in time, and co-locating services can reduce duplication across systems and really support maximization of the existing funding streams. When staff are trained and supported, they can respond to behavioral health needs more confidently and effectively, which also creates a stronger, more efficient, and more effective workforce. Go to the next one. As a part of the multi-tiered system of supports, Minnesota's school-based behavioral health services strengthen the continuum of care that ensure appropriate mental health supports for all students. So this is a nationally recognized model that is also promoted through school-based services at school-based mental health services in Minnesota. And we know that this really increases the supports because when students get the needed treatment and support at the right time, in the right amounts, and at the right level, it can have a direct impact on reducing or improving their outcomes and also reducing the need for additional interventions in school settings, things such as seclusion, restraint, and also going down correctional paths as they might be experiencing challenges within a school setting. It is really improving the outcomes for those youth that receive this type of intervention. And it really has a different approach at each tier to support youth. So if you look at tier 1, that's a universal strategy, really looking at interventions for the entire school district and for all youth there. And it kind of gets more targeted as you climb up the pyramid. DHS and MD have long worked in collaboration to meet the needs of youth in schools and continue to grow supports in this area. Just wanted to highlight on this slide some of these collaboration efforts that have been occurring in the past years and really show that this is an important area that systems really need to work together on. Children do not live in isolation. We all know that. They cross across multiple different entities, multiple different state agencies, multiple different systems in Minnesota. And when you can have those collaborative planned approaches at a state level, it really helps, again, just to create better outcomes for those youth. So some of the areas that the collaboration has been occurring include data sharing, positive behavioral intervention and supports, and alignment of the school-linked behavioral health grants, joint trainings, coordinated support of evidence-based therapy techniques through training and supports and technical assistance. There's a Project Aware grant, which is a federal grant that promotes supporting mental wellness in schools, but that federal grant actually requires a partnership between the state mental health agency as well as the state education agency in all states. There's another grant that also supports school work at this point in time from the Center for Medicaid Services, and it's really focused on expansion and support of school-based behavioral health services through the CMS grant, so another funding stream and another way that service and support is being developed in Minnesota. There's also collaboration, including interagency agreements, to develop crisis response teams that are really focused on school safety and response in the school system. So we're going to move a little bit into, you can go to the next one, schooling behavioral health. That's it.
Do you want me to go to the next one?
No, sorry. All right, so we're going to move a little bit into more in depth about the school-linked behavioral health grants. So the school-linked behavioral health grants are grants that go to community providers working in partnership with local schools, again, to support youth who are uninsured or underinsured, as well as supporting their families and school staff that are working with those youth. Grants go to providers who support various types of school districts. The different school districts can be independent, charter schools, and specialized districts, as well as to intermediate school districts that are the schools that are providing highly specialized educational programs to students with the most complex needs. At this point, there are currently 4 intermediate districts in Minnesota that have received school-linked behavioral health funding. And the grant supporting these intermediate schools is really integral to returning students to their home districts after they are completing their treatment. Again, the funding that goes to these districts and the community partners that support these districts are really supporting those highest needs and most complex youth that typically have been placed out of home, received residential treatment, and are needing some more intensive supports and services as they then continue to transition back to their districts. This slide shows a map of all of the current school and educational program locations in 2025. So you can see on the left side, I believe, the saturation and the increase in numbers served throughout the metro and greater Minnesota areas. A count of districts served by the school-linked behavioral health grantees organized by district type and geographic region with statewide totals for comparison is presented on the right side of that slide. If you look at all the various individuals and schools that are supported at this point in time through the School-Linked Behavioral Health Program, there's a total of 328 districts that are being supported and served statewide. Another piece of data to go through is really showing the trend of funding over the past few years. This increase is great and continues to rise, and the ongoing allocation in fiscal year 25 and 26 is really allowing for consistent funding levels to be maintained for the School-Linked Behavioral Health grants at about $22.5 million a year. That's an amazing amount of funding, an amazing amount of support for the state and for community-based providers to be going into schools. And we know that even with this allocation, the need is greater. The most recent RFP that was put out by DHS had requests come in that totaled around $40 million, and we had 22.5 to allocate. Still a huge support to the state, and just from that request that's coming in shows the greater need that is out there. This chart is describing the number of schools, which is the blue bars, and the districts, which is the green bars, that have school-linked behavioral health providers. You can see the growth continue over the years and the number of the FTEs, which is that dotted light blue line, providing services in the schools through this grant continuing to trend up over the past few years. There is a slight decline, I can acknowledge, in the 2020 to 2022 timeframe from the provider area, which we know is a direct result of the impacts of the COVID-19 pandemic on the behavioral health workforce. We are unfortunately in the midst of a national behavioral health workforce crisis. We continue to rebuild and bring staff into the field to continue to support, and so we're seeing the growth again on this chart. And yet we know just from reports that are put out and studies and national information that we get that there is this trend where those retiring and leaving the field as mental health and substance use providers far outweighs the number of new students coming into the field. So we continue to see the struggle of being able to have enough providers to support the needs. This graph is showing the number of students served per year with a total of 22,007 supported just in the first half of 2025. You can see in this chart that it tends to go up and down with a lower point in certain timeframes, and I would say that that really is a normal range of what should be happening as it really coincides with when school is in session. So when school is happening, our numbers being served are higher. In some of the summer months, obviously with school not in session, the numbers go down. But it continues to rise. There continues to be an increased demand, and our community grantees continue to work to increase their capacity to provide more services to the students that are needing these services. I did want to spend a little bit of time just talking about some of the services that support behavioral health needs in schools outside of the grant funding. So in addition to grants, there is now the ability to bring in even more services and supports with the continued expansion of Medicaid billing and generating revenue through the Medicaid programs in school settings. This increase in the revenue can also support schools to provide more school staff to support students such as social workers, counselors, and those individuals through some of this expanded billing opportunity can then help to prevent and or treat behavioral health concerns. So it's another way to meet the great need of mental health and substance use challenges within school districts for students going there. We also have the mental health and special education benefit, which allows for behavioral health services to those highest and most complex youth to receive treatment and supports through billing through their IEP. I can also highlight that this mental health and special ed benefit also expands to other services, other health-related services that are important through IEPs, not just mental health. But one of the great benefits is that you can actually bill through IEPs for mental health services in this new benefit. Go ahead. This graph illustrates the continued growth in Medicaid billing for school-based behavioral health supports. With, when you look at that chart, 23 to 24 is about $79 million. We know having appropriate supports in place and necessary treatment allows crises in schools to decline. It improves outcome for the youth that are accessing treatment, and it can also support the lessening of the use of restrictive measures as youth and the adults around them learn skills to assist with de-escalation. When youth and the adults around them learn different ways to handle when you might be dysregulating, it can, again, help them build skills, but also help those adults around them to learn different interventions that decrease the crisis from occurring. So the more that we can help build skills, the more that adults interact in a different manner and learn the skills to help de-escalate things, the less we have to use restrictive measures. So good benefits all around. Next slide. Yep. We know that the additional mental health and substance use supports to schools can improve outcomes for youth across the board. A part of improving those outcomes with increased supports in school districts is, again, the ability to lessen the need for seclusion and restraint, which we know is not a best practice and can increase harm to youth. There's studies that show it can increase adverse childhood experiences and increase trauma that might be experienced. And we also know, on the other hand, it can be really challenging when children are in crisis and escalating. We don't want any students or any person to be unsafe to themselves or others. So again, looking at efforts like School-Linked Behavioral Health, Project Aware, and information found in the MD legislative report, really talking about how to work together to lessen those incidents, are really important to continue to support and move towards as we continue to develop the system of care in Minnesota. Moving towards positive behavioral interventions, training for the adults working around the youth, and providing necessary treatment and supports really helps us to develop the system and get to a better place where hopefully we can lessen the use of other interventions along the way for those youth. So just in conclusion, we know that the efforts are working. School mental health staff, such as counselors, social workers, and therapists, can directly have an impact on improved outcomes for youth, reduction of seclusion and restraint by preventing crisis through early identification, de-escalation of behaviors using trauma-informed techniques, and making sure to connect students to ongoing supports like therapy or family services that continue to help build those skills and intervene before escalation occurs. The presence and training of all school personnel can enable proactive interventions, and that can really help to address the root cause rather than a reaction intervention when youth might be experiencing that trauma and that crisis. That can really help to result in fewer triggers, which then the behaviors don't occur, and promote safer responses when the dysregulation might be happening. So I think we have a little bit of time for questions before the next presentation, but.
Thank you, Ms. Steinmetz. Any questions or comments from members of the group? Ms. Heiser.
Thank you, Chair.
Sorry.
Sorry, I gotta get a little closer here. Thank you so much for your presentation. Appreciate all of this very thorough information. I just had one quick question about slide number 5, which was on the multi-tiered system of supports, or MTSS. There's an interesting note here about the tier 3 supports, noting that, this is the top of the pyramid, so obviously it's the smallest amount of students. And it says historically, tier 3 supports support 1 to 5% of students, but now may exceed 20% in schools. I wondered if you could just tell us a little bit more about that.
Ms. Steinmetz.
Thank you, Chair. That's a great question. I think it really contributes to the increased struggles that youth are experiencing. We know that the interventions, the mental health needs of children continues to rise, and it drastically rose after COVID and just going through that isolation period and all of the effects of what happened, and the needs of children continue to increase. So we see more anxiety disorders, more depression, really more kind of trauma impacts on our younger generation at this point in time than we've probably ever seen. And I would really deduct, not knowing for sure, but I would deduct that's why we're seeing that need for a more increased intervention at that tier 1 level.
Ms. Heiser, anything else?
Thank you, Chair. I noted the variety of funding sources, and I'm pleased to hear you say, and I'm pleased for the increased funding of the state legislative appropriations. But I think you made a really good point around the fact that as we continue to increase our support of behavioral health supports, we also increase the need. And that, you made the point here around, the restrictive procedures and the seclusion are not the best practice. We want to increase the mental health supports and not have to use those restrictive practices. So I'm quite concerned, as you might imagine, around some of the federal grants and where those might go. I'm wondering what your thoughts are simply around what we need to be doing as a state in the potential absence of those federal grants moving forward, and the increased need that we're seeing, both quantity and quality of the supports that the students need.
Ms. Steinmetz.
I'm sure. Another great question, and I think, as I said, at this point in time, it's even more important to think about how dollars are being utilized, knowing that some of the federal funding is going away. We have changes to Medicaid coming, and not be duplicating services. So I think as a state and a government, we really need to plan and think about how we're utilizing our dollars, not overlapping with each other, but to stretch the services and needs. So those who can access Medicaid benefits, let's use those as much as possible. When you don't have access to that, we should be using grant dollars. And then we should be thinking even bigger picture about all of the grant and funding for behavioral health, specifically in schools, and how to make sure that we're not duplicating and that all kids are able to access when they need it. It's still not this magic wand solution, but it's a way to stretch the dollars more. And then as much as we can think about how do we use ongoing existing state funding to kind of fill those gaps as well when those other benefits and federal dollars have gone away as part of the planning that I think should occur.
Ms. Heiser? All right, Ms. Sandsmark, did you have something?
Thank you, Madam Chair. I just had a quick question, just a follow-up to the 20% looking at the exceeding need for tier 3 intensive supports growing. As we were talking about earlier, I'm just curious if there's any data, if there's the concentration of these students and this increase is happening in certain communities. Is it happening in different, say, rural versus urban communities based on race? I'm curious if there's any data on that.
Ms. Steinmetz.
I'm sure there is. I do not have it off the top of my head, but I'm sure that there has been analyses done of billing increases in throughout the state, certain areas, gaps in the system. So definitely can see what we have and pull that together and get it back to the group.
Ms. Ansark, anything else? Any other discussion or questions from members of the group? Ms. Woodward?
Thank you, Chair Seeberger. My question is just around the research that you cite from the U.S. Government Accountability Office, and I'm curious within that research if that was paired with specific recommendations. I appreciated some of the information that you shared and how when you add in these supports, it reduces the need for seclusion and restraint, right? And we've had a lot of conversation around this table. Nobody wants to engage in restraint and seclusion. And I'm curious if you are knowledgeable about specific recommendations that came with that research.
Ms. Steinmetz?
There is, and I think we might have linked to some of the reports in the slides. Otherwise, we can get them for you. But there are definitely national reports that are saying, here's some best practice models with recommendations of how to continue to improve the system, things to really work on, focusing on to help move the needle in that area. So we definitely can provide those.
Any other questions or discussion from members of the group? All right. Really good presentation. I had a few questions. You did touch on the goal of equitable access and sort of to piggyback on the question asked by Ms. Sandsmark. I'm wondering, do students in Greater Minnesota have the same access to these services as schools in the metro area? And I'm thinking in terms of just provider availability, resources that the schools have. If you can comment on that in any way.
When you look at the map on whichever slide that map is on, it definitely is condensed in the metro areas. And I do think that provider capacity and access to those resources plays a factor in that. But there are providers throughout the entire state. So it's not perfect, but it is expanding and getting throughout all of Minnesota, at least the schooling behavioral health grants, and that is a focus that we continue to have. And with that being said, it is challenging when there may or may not be a provider or one or two providers in those areas. So I think that is definitely a struggle to make sure there's consistent access throughout the state.
I'm struck by and we've heard this before, but I'm struck by the significant growth in the mental health needs of our students across the state here, and I would imagine probably across the country. And I know that funding has increased, but I question whether funding has kept pace with the need, or if it feels like we're just continuing to chase our tail and catch up. What are your thoughts on that?
It's a great question. I think when you have requests for funding coming in that are double what we have allocated to put out to the state, there definitely is always that pressure of the needs that you're seeing. And it is just it's a unique environment. I mean, I've been in this field for 30 plus years, and the needs that we're seeing now are more complex. They're in more youth than we've ever seen, and they continue to grow. So I think it's hard to keep up with the need that's out there based on the funding that's in existence. And then on the other hand, we also have decreases in some of the COVID-related federal funding that came in. It's no longer there. Like, there were things that were in place that helped for the past few years that are now no longer accessible to states. So that also plays an impact. The other piece I would just say is that one of the challenges is that reimbursement rates for Medicaid services don't always keep up with the need of those accessing it either. So if you don't have strong enough reimbursement rates, providers have a hard time providing the services and staying in business and keeping their doors open. So those all play a factor in this trend that we continue to see.
And I think that's something we see across the board in healthcare generally, in
sure.
terms of Medicare and Medicaid reimbursement rates being so low, just not being able to cover the costs of the services that they're asked to provide. One question I thought of, and I'm thinking, we talk about the state grants, the Medicare, Medicaid, some COVID funds, different kinds of public funding. What role, if any, does private insurance play in covering the costs of school-linked behavioral health services or mental health services that students receive through school or through DHS?
That's a good question. I know that private insurance will cover typical outpatient service benefits. Sometimes it is harder, and I'll have to do more research to know exactly what is and isn't covered in a school setting when it comes to private insurance. We can definitely get back to you on that. But they don't always cover the same intensive services that Medicaid might be able to support when you have a child with more complex needs. And so that's always one of the struggles for youth who have private insurance coverage, which is great, but sometimes that doesn't give you access to all of the same benefit array that you might get with a Medicaid coverage.
Yeah, and I can speak from experience. We ran into that with our family. I mean, I'm insured through this job. We have great benefits, right? But certainly my son didn't qualify for a lot of the services that were out there just because we had private insurance. So the process of transitioning him onto MA so that he can access these services has been sort of bewilderingly frustrating. And even private pay, even saying, well, can we just pay out of pocket for some of these services? And the answer is no. It has to go through MA, which seems to me counterintuitive and really frustrating when we're dealing with limited funds in the first place. The ability of maybe a family to cover some of these costs, but there's simply no option to do that, seems bizarre. I just make that observation. One question I had for you, you have the attention right now of this work group and legislators who are involved in this, trying to craft solutions or goals to help make things better. What would you like to see the legislature do? What can we do to help?
It's a good question. I think just looking at the increased needs when it comes to mental health substance use challenges throughout the state, ideally, I mean, being able to have the right amount of funding to actually support the requests coming in for grant funding for school-linked interventions, as well as continuing to improve rates and expand services wherever possible. Those are all key factors in transforming a behavioral health system of care to really be able to meet the needs of individuals, specifically youth, who we know are the future, right? So we always want to be thinking about them better than we are right now.
All right, any other questions or comments? Thank you both very much. Oh, yes.
Madam Chair, can I just add one
course.
thing related to the issue of reimbursement rates? There is a public report that DHS issued a few years ago specific to reimbursement rates for mental health services as well as substance use disorder services. So the legislature took a really good look at that last session and made some effort to look at those reimbursement rates. I don't think that the funding mechanism that was used will be allowed by the federal government. So that is one thing that we would love to continue to work with the legislature on, is getting those reimbursement rates up to at least covering the costs that providers have to delivering these critical services.
We had a lot of conversations in the legislature about reimbursement rates for Medicaid, and the last session was particularly challenging, trying to get a budget done and seeing cuts being made in the areas of human services and impacting the people that need it the most and taking the money away where it can do the most good, which was particularly frustrating for me and for a lot of people. And then watching the federal cuts coming. And it's so frustrating to know that the money is just not there when we need it. So we'll continue to work on that. You have my commitment. Lift every stone and every couch cushion to find all the money that we can to help our kids. Thanks for your presentation.
Thank you.
Next, we have Mark Sander from Hennepin County, who is the Hennepin County Director of School Mental Health. Whenever you're ready, you can begin.
Perfect. Thank you. All right, Madam Chair, members of the work group, thank you for this opportunity. I'm Dr. Mark Sander. I am a senior clinical psychologist and also the director of school mental health for Hennepin County. My colleagues at DHS covered a lot of this content, so I want to be mindful of time. So I might skip through some of my slides quickly because they've covered a lot of this content. But you know, and as we've already talked about, there is a significant gap between the mental health needs and available services. We talked about, 1 in 5, and now there's some research saying it might even be higher. Youth have, a diagnosable mental health disorder, yet, 70% are not able to get adequate levels of treatment. And so that's where coming into schools is so important in providing, and then even in, this is some older data, but we found even in kind of more low income and urban communities, when they have access, they might only be able to make 4 sessions. And so coming into schools is just this really great opportunity. And the other point I want to note just in this part of the data is we know that 50% of the adults with mental illness had symptoms before they were 14. So connecting with them in schools, bringing the service there, making it accessible is so important. And we also know, and again, my colleagues from DHS have already talked about some of these barriers, but again, there's a lot of barriers for family and youth to get connected to care. Some of it is financial and insurance. Some of it is also just accessing care. If you've got to go out to community-based care, you've maybe got to get childcare for your other child. You need to transportation, and a number of years ago, a parent who was accessing school-based mental health talked about if they had to take off work every week for 3 to 4 months to get their son or daughter to the support they needed, they were worried about losing their job. And there's other barriers, maybe past experiences weren't great. We all know there can be waiting lists and just the stress of accessing care. So this is why having services in schools just makes so much sense. Why also schools? And again, this has been touched on a little bit, but I think it's so important that there's this great opportunity in schools to start this conversation. And I've done a lot of my work in the Minneapolis public schools, as well as across Hennepin County. And over the years, having therapists in schools creates this culture that it's okay to ask for help. And, I've had youth tell me that, and that's oh, it's just, down the hall, and it's, It's not a big deal to go and, yeah, I'm gonna go see my therapist right now. And so providing this level of access in schools really, really helps decrease the stigma that can be around mental health. I also want to acknowledge the work that school-employed staff are doing. So a lot of the data that I'm going to share is about the therapists that work for mental health agencies that got embedded in schools. But I really want to, this partnership, and you saw the MTSS triangle, and schools and like school teachers can really be working on culture and climate in their classroom. They can also be working on social emotional learning and have other staff. They can be doing multi-tiered systems of support and really having our student support staff, our school social workers, school nurses, school counselors, school social workers, really coming in and being that first layer of support, right? Like, hey, we can do, a brief check-in for 15 minutes. And then as the need for that young person gets maybe more significant, then they're able to hand off to somebody else who's able to do more intensive kind of mental health treatment kind of work. We've talked about this, so again, like the goals are to really improve access and engagement in mental health services, and really focusing on improving mental health symptoms, but also improving the school outcomes. And I've got some data around attendance and suspensions, and also really to build up the confidence of school staff to be able to support youth mental health. And because oftentimes, right, it is the youth goes to their teacher and says, hey, I'm feeling this way, I've got these concerns, and at least then the teacher knows, hey, I can go and talk to that school social worker and get them connected somewhere. But again, we want to really have that openness about giving educators the confidence to have those conversations that might sometimes feel scary. All right, so a little bit about Minneapolis. I was very fortunate. I was at the National Center for School Mental Health as a postdoctoral fellow, and then on faculty before I moved back to Minneapolis in 2003. And then just a little while later, I stumbled on this opportunity to help Minneapolis Public Schools build a school-based mental health program. So at that time, we started with a full-time therapist in 5 schools. That's in 2005. Now in Minneapolis, they have therapists in over 64 schools from 10 different mental health agencies, serving roughly 2,000 students a year. Across Hennepin County now, we have 22 different mental health agencies that are in over 220 schools with over 230 FTEs, or mental health full-time equivalents. So basically 230 staff in those buildings, serving over 7,000 students. So what does it look like? So again, I think when we talk about school-based mental health, it's important. A lot of the work is around providing those clinical individual or family therapy. Therapists can also go see a youth in their home or in other spaces. They are capturing insurance revenue whenever possible. It's also really important to have what some of the state grants do is funding this ancillary support. So being able to have that therapist talk with that student's teacher and let them know, like, hey, here's what we found out with Johnny around his anxiety, and here's a couple of interventions that might work well in the classroom. So being able to fund those conversations between the therapist and that young person's teacher is critically important. Also doing coordination with individuals outside of the school, could be a pediatrician and other individuals, and then continuing to do professional development for school staff on mental health topics. And then also having that therapist come in and have time to come into a classroom and give a presentation to students on different mental health topics. Because one, there's the education, and then two, they get to know Dr. Sander or Dr. Mark, like, oh, he's kind of a nice guy. He's not so scary. Like, okay, I could go talk to him. So I think, again, providing that exposure of our therapists with students and teachers is critical and not always paid for by insurance. So what does the data say? So what we found was for students, and this comes from Minneapolis, so 85, and this is from a while ago, but for students whose parents said, yes, I'd be interested in hearing from a therapist, 85% of them had a conversation face-to-face with a therapist. There's another study done when they just do a referral out, only 13% connect. So it's so important for that one-on-one connection. The other thing that I want to point out is more than half of the youth who were seen, this was their first time ever getting mental health support. And that comes from research that we did in Minneapolis. I know DHS also has data from their grantees. Year after year, half or more of the youth that are getting access, this is their very first time. And we also had a study where showing that actually BIPOC students were more likely to access mental health services in schools than Caucasian students. So again, I think it's providing them access at school makes it more accessible. We also have data using the Strengths and Difficulties questionnaire from both parents and teachers showing impacts on reducing emotional and behavioral problems. There was a study, and it was in my materials I sent, that the University of Minnesota recently did that found, and this went across Hennepin County, looking at, I want to say, more than 10 years of data, found that school-based mental health reduced suicide attempts by youth. And as you've heard from me and other, we also have data showing reduced suspensions. But I also want to say, what does school staff say? So there was a study done back in 2016 where we actually asked school staff, what do you think about the school mental health work here? 92% said having therapists here make us more mindful of having this conversation. 80% agreed that services on site increased availability for clinicians to help students. And they felt like having services in schools made it more welcoming to parents. What did parents say? Parents said the collaboration between my therapist, the school staff, makes them feel more connected to school. We know that's so important. 76% said their students' relationship with school was improved, at least a little bit or a lot. 75% said their students' interest in school increased. 88% said my child had a greater sense of belonging to the school community. And 75% said their children were more involved in school. And this is all because they had a therapist who was in their building and able to make those connections and make them feel confident and help school understand the mental health needs of the young person. And that is it.
Thank you, Dr. Sander. Any questions or comments from members of the group? Ms. Iser?
Thank you, Chair. Dr. Sander, thank you so much for your presentation and good news presentation in general, which we don't get a ton of. But my question for you, because we are the Seclusion Working Group and you're a clinical psychologist, is I wonder if you have any thoughts on the mental health impacts of students who have seclusion, who are secluded, who are under restrictive procedures. Any, I'm not asking you to cite data or anything, but just any sort of like consensus from the psychologist community around the impacts of seclusion and restrictive procedures used on the, when the mental health of the children is concerned afterwards.
Dr. Sander?
Thank you for the question. So that, it is not my area of expertise. So I think what I would come back to is just saying, I think the more that we can have these kinds of supports in schools, I think will lessen the need for other, like, for seclusion and those kind of, like, we're gonna have more mental health supports available to youth, and then we're gonna have hopefully a workforce that is better informed around how to support mental health needs for youth.
Ms. Iser? Any other comments, questions from the group? One question I had for you, Dr. Sander, is the Hennepin County built out this program, sounds like starting in 2005, to really address the mental health needs of students, and that's really phenomenal. I mean, it's, I think, addressing a need that probably has always been there, but we haven't been willing to talk about or address or really work on. So I think that's great to hear. Where did the funding for this come from? Is it come from the district? Is it state funding, federal funding? Do you happen to know?
I do. It was one of the slides I took out when I was trying to shrink my talk. So I will say the funding, probably 70% of the funding comes from health insurance, either public or private. So that's critical. Then, as was mentioned earlier, we really need to be thoughtful about funding for the uninsured and also the underinsured, because one of the things as we bring services into schools, we want to make sure that any youth has access, regardless of their ability to pay or not. We don't want that to be something that our agencies or school staff need to think about. So so the state school link mental health grants are helpful there. I will say a number of school districts will buy the ancillary or the consultation service, right? Because that's the consultation. They're very mindful about, so they will just kind of buy that. So it is a mixture of funding streams. And then we also sometimes have philanthropy, like some of our agencies have been able to find to get support, but most of the funding is public or commercial health insurance. And then the DHS School Link Mental Health Grants, then I want to say probably school districts, and then Hennepin County also provides some funding as well, so.
All right, thank you. Okay, no other questions from the, oh, I'm sorry, I misspoke. Ms. Winship, you had a question or comment?
Yeah, thank you. Thank you, Madam Chair. Thank you for both of the thorough presentations. Those were both excellent. And I agree, as a Minneapolis Public Schools school counselor, we have some amazing mental health providers within our buildings, and they make a huge difference. And they stick around, which in other districts, often they kind of cycle through. We have therapists that stick around and really do make a difference. And I agree that the normalizing of mental health therapy among students, I was just talking to a colleague the other day that in my 15 years as a school counselor, I've never had so many young people so open to and willing to engage in therapy. And at the same time, we need more. So I work specifically with our high school students experiencing homelessness. And when I get a student that is willing and ready to engage in therapy, I need access immediately. And all of our high schools have wait lists. I've never, in my 5 years in Minneapolis, I've never been able to get a student right into therapy. And so that, again, just tells us that we need more because it is so important and it's needed and wanted. And it really does help a lot in the building. So I just wanted to add that anecdotal part. Thank you.
Thank you for that. I think the theme here is the need greatly outweighs our ability to address that need, but certainly I think we're moving in the right direction. Yeah. All right. Thank you, Dr. Sander.
Of course, thank you very much.
All right, any time for discussion? Do we have any discussion or questions on this topic from the group? Ms. Hansmark.
Thank you, Madam Chair. I just want to affirm, well, thanking the presenters and thanking you for bringing them here to really emphasize the need for direct service in schools and just how vital that is. I know that's a big point of importance for a lot of the families we work with, and I just want to affirm that whatever we can do, and I'm not a legislator, I get to come here and speak on behalf of a lot of families I get to work with, but I know that direct service in schools has been a huge support for them, and lack of access is a huge barrier for those folks. So I just want to affirm that, and I'm really grateful that we're speaking about it in the work group today.
Yeah, it was a game changer for our family. When my kid was in middle school, and this was back, years ago, it was news to me that he could get these services while he was at school, and it was a great help for my family. At the time, my husband was mobilized in the military, so I was a single mom working full-time as a trial attorney, and it was really, really hard to find time to get him to outpatient therapy services, and that ability for him to just kind of seamlessly transition as a part of his school day and receive those services helped us be able to, because when you have a stressed mom trying to get a kid somewhere on time, right, it's not always all that productive. But it was a game changer. And then that therapist got to know my kid really, really well, established a relationship. So I do see the value in incorporating those services within the school day, and I would like to see us as a legislature fund that appropriately. Obviously there's so many competing things competing for limited dollars, but I do think that if we can make this investment in the front end in our kids, and it was compelling to me to hear that 50% of adults that have a diagnosed mental illness showed symptoms prior to the age of 14. I think that's compelling, where we can really direct our dollars to get the most effective use of them. Really strikes me. Any other comments or questions from the group? Yes, Mr. Haveman.
Thank you, Madam Chair. So as I listened to the first presentation, and first of all, great presentations, both of them. Thank you both for coming forward today. At 916, I'm proud of the fact that I inherited a job over here. I guess I got the job. I didn't inherit the job, right? And yet I inherited staff that are what I consider to be overachievers. And so when I look through all of this and I look at the school-based community services, the mental health and special ed, the school-linked mental health, Project Aware, MTSS, I mean, all the way through this, we do all the things, and we actually do them quite well. And I'm grateful for all of it. We need more of it. We need more of the services. We need more of the supports. We need more of the mental health. And yet, even with all of the things being done well, and we don't have a lot of waiting lists like we did back when I was in Lakeville or Hastings for our co-located or our school-linked mental health services. And so we do have kids that get access to those providers when they need them, and yet we still have seclusion in the mix. And so to the point that you've made, Chair Seeberger, like if we make seclusion go away, what is going to be our alternative? Are we going to be calling the police? Are we going to be calling the paramedics? Are we going to be cutting school days shorter? Because even with a district that's doing all the things, we still have this as a need. And we're trying to reduce it. Like we talked about bringing in UCARO, and we are bringing in UCARO. We're hopeful that that will continue to reduce it, just like some of these other measures have. I hope we get more funding to be able to do more of these things as well. I hope that whenever Project Aware goes away, which is at the end of this year, we're not sure what we're going to do with some of the programs that came online via Project Aware. So I'm just wondering what's next.
That's a great question. And I think it is worth pointing out that there is no magic solution here. These are all supports that do benefit our students and do meet needs. But you're right. You can do everything right. You can provide really high quality services for students, but those with very complex needs still sometimes you're going to have an incident, and it's just the way it is. I have not heard of the magic 100% effective de-escalation technique. I have not heard of the end-all be-all solution to our kids with really significant needs. I've wanted to know what that is. I'm sure you guys all want to know what that is. I don't think it exists. So I do have concerns, again, as I've said before, about eliminating a tool in the toolbox that can be useful, but then, as we know, is often misused. And I've been doing a lot of thinking about this, and it occurs to me that we can have, and we've heard information about the tool being used. People will have experiences with seclusion that, again, while nobody wants to use it, have found it to be a useful tool, but we've also heard of it being misused. And despite the fact that seclusion as a disciplinary practice has been banned in the state for dozens of years, it's still happening. So why is it still happening? And even if we ban it entirely for use in an emergency procedure, if having banned it as discipline, it is still being used as discipline, by taking away that one remaining tool, what are we solving? So that is what I've been wrestling with in my own mind. And so I think next meeting, we're going to hopefully get some information on the misuse of seclusion and try to get some data. Where is it happening? Why is it happening? What are we seeing? Because we did ban disciplinary seclusion a long time ago, but it's still happening, is what I'm hearing. So I want to know, that's where I think we need to explore. Where is it happening? What's going on? And how can we extrapolate from that to understand the supports that are needed so that it doesn't happen? Because my concern is if we take away the tool in emergency uses, how is that going to solve a problem if it's already being misused? Do you know what I mean? So that's kind of where, that's where I hope to focus our discussion next meeting. so that we can kind of dig into that a little bit. I think we've heard some really good things on what schools are doing. We certainly have seen what 916 and 917 are doing. We've seen the efforts that Minneapolis schools have made to eliminate the use of seclusion, but we still see restrictive practices. We still see restrictive holds. We still see schools that have a policy of no seclusion that have to report a use of it anyway because of, you know, whatever happened during that particular incident. So I think it's good that we're being really thoughtful about this and differentiating between seclusion used for an emergency procedure and the misuse of seclusion, either during an emergency, contrary to the factors that are set out in Minnesota law, or used as discipline. And in fact, I think that online meeting is tonight, which I intend to attend. And again, it was billed as using seclusion as a disciplinary practice. So that rubs me the wrong way when I hear that, because it's not what schools like 916 and 917 do. It's not what any school is supposed to do. And if it's still happening, I think it's important that this group examine what's going on. Because I think only through understanding where it's happening, why it's happening, can we start to address the ability to really focus on the root cause and see if we can't outline a strategy for impacting that. So, I don't know, I got a little meandering there. Ms. Woodward.
Thank you, Senator. I was really curious to learn more as we were listening to the presentations, and I agree, just great information. And one of the themes I kept hearing is when we do things, it reduces the need. It reduces the need. Increased supports reduces the need. And then just the citation to that research that had been completed by the Government Accountability Office. And in taking a look at some of that, that struck me as doing, you know, a little searching. But a lot of the recommendations there do center on data collection, underreporting, high reporting, accountability measures, tools that education departments use to explore misuse. And I think there's just some really solid recommendations in that regard. And I haven't obviously read the research fully. I haven't explored every single one of the recommendations, but some of the top, most prevalent recommendations are about this piece specifically. Not about removing the tool, but about the accountability and the structures used for reporting, and then what thresholds trigger action to then further explore with that particular district or program when either data is very much underreported or highly reported. So I just wanted to mention that I think it would be wise if the committee hasn't looked at that perhaps between the meetings that we take a look at some of those recommendations in that research and report that was provided. There's summaries posted on the Council for Exceptional Children website, many places with a quick Google search, but I think it could be very informative and help guide our conversation.
Thank you. I think that's a good idea. So that at least we all have that information and come prepared to have that conversation. Ms. Heiser, did you have a comment?
Thank you, Chair. Nicole's point triggered a question for me. I asked the question today around the impacts of seclusion, the illegal use of seclusion or the legal use of seclusion, because there are a lot of resources out there about what a child or an individual with a disability goes through after they've been secluded. And so my question is around the resources. Today we were provided with several studies or articles to read. I just am wondering, purely from a logistical or administrative question, I suppose, would be when we are provided the resources or not provided the resources, what's the decision-making behind that, and how can we make sure that we're all accessing the types of resources like Nicole just referenced, or I'd love for us to discuss the mental health impacts of seclusion, regardless of how it's used. So I'm wondering how they get to us or how they don't get to us, I suppose. And that might be a larger question for the group as a whole.
Do you mean in terms of the studies? Like, for example, we have articles included with our materials today. Is that what you're asking? Like, how do these get in front of the work group?
Thank you, Chair. Yes, that is the premise of my question, because I think the second piece of that would be, since we weren't able to hear today about the mental health impacts of the use of seclusion, maybe we could find some more of those studies that we could review together, if not from live testimony.
I think that's totally appropriate. And we can, I mean, in terms of items to discuss in upcoming meetings, I think we have a little bit of leeway.
Like, if there's like research data, certain things that members want to bring to us, like we can compile that and have that as an agenda item or a thing on the website.
Yeah. So if members have research or articles that you'd like to provide to the working group, if you send those to Andrew, we can get those compiled, and I think it would be appropriate at some point to devote some time during a meeting to discuss that. We can all have a little homework to do, read through whatever folks want to submit, and then reserve some time at a future meeting to have that discussion. How does that sound to you, Ms. Heiser?
Yes, thank you, Chair, and thank you, Andrew.
Anything else on our minds? Ms. Woodward?
At the end of the last meeting, we had quite a bit of conversation, just, kind of some back and forth around, man, can we get to some ideas? Can we talk about some solutions, some potential things to toss out and look at? And we had conversation about things like parental consent and the IEP process. And, I'm just curious when, been giving that a lot of thought. We're 3 special education administrators, which is the lens we bring to the table. And we have a high level of knowledge around and experience with those processes. And I think we're uniquely positioned to bring some solutions to address some of the concerns that were brought to the table. And I'm just curious when would be the best time to maybe outline some of those specific ideas for consideration, if that's the next meeting now. I'm just curious on that, because I've been giving that a lot of thought about ways to support kind of both perspectives with some potential solution ideas.
And ultimately, yeah, that's where we're going to come up with some recommendations. I think Andrew and I were talking about this. We're looking at starting December to start bringing some of those recommendations forward. The final piece, we've done a lot of talking about seclusion, what it is, what it isn't, when it's allowed, when it's not allowed. I think one of the final more significant pieces we haven't talked about is the misuse, and hearing from those who have experienced that. I think we touched on it briefly 1 or 2 meetings ago, but I'd like to focus our next meeting on that, so that we get that piece of the picture filled out as well. And I think as a group, to try to explore, again, why it's happening, because if we can get to some understanding of why it's happening, hopefully that would inform us as to how we can prevent it from happening. And I have a lot of concerns about resources that are available to Greater Minnesota, and what we can do as a legislature to support school districts in Greater Minnesota that don't have intermediate districts to rely on, and that have a smaller student population, and therefore have maybe a few students with significant needs, and that school has to try to figure out how to spin up a setting for a program for that student. So how can we support Greater Minnesota schools that now find themselves relying on suspension or other things that are not optimal just because they have limited resources or no other means to really support that student. So that's been weighing on my mind too, and I'd like to see us kind of wrestle with that a little bit too. But I think starting in December, we'll start compiling recommendations, and as a group, kind of sort through those recommendations on what we can bring back to the legislature that can hopefully begin to address the issue. And I'm hopeful that we can come up with a bunch of creative solutions or ideas anyway that can begin to or continue to address the issue of seclusion in schools. So hopefully that answers your question. Okay. Any other thoughts or discussion today? All right, I'll give you a little bit of your day back. So our next meeting will be on November 19th at 2 p.m. in this room, room 123. We'll be talking about the misuse of seclusion. And I think that's it. All right, there being no further business before the work group, we are adjourned.